So good morning everyone, welcome to you all to Diabetica Gujarat chapters meeting of RSSDI and to the Sanskar Nagari of Baroda. We are discussing about setting and adjusting basal bolus insulin for optimal control, and it's a workshop, so I would like to have involvement of all of you. Initially we will discuss very basic thing, because in country like India we have lots of patients having type 2 diabetes, but our control is not good. When we see data, we find that our average HbA1c is around 9, and that is not good. And to control this HbA1c less than 7, we have to do many things, and insulinization is one of them. The data shows that we start insulin 6 years late when it is actually required. So from the chairpersons and from the audience, I would like to know that what are the indication of insulin in type 2 diabetes? With quick raise of hands. When we should start insulin in diabetic, specifically type 2 diabetes? There is a sign of any glucotoxicity?
No.
We can start at very initial part of the diagnosis of type 2 diabetes, then?
Not controlled with 3 or more.
Not controlled with 3 or more OHA, yes. Any infection, yes. So these are some indication we should start insulin. What is the ideal way of starting insulin? Whether we should start with the basal insulin or bolus insulin or basal bolus therapy, what should be our goal of starting insulin therapy in type 2 diabetic?
The patient is on more than 3 OHA and still not controlled, then we would like to start with basal insulin at night time.
Exactly. So if the patient is already on multiple OHA and we see that patient fasting PP A1C is not under control, we should start with basal insulin. Now can anyone tell me what are the options for basal insulin for us? Yes, glargine 100, glargine U 300, then degludec. We can start? Yes or no? So at what dose we should start now? Yes, then we have to see the glycemic status of the patient. If the HbA1c is more than 8, we can start at 0.2 to 0.3 unit per kg, and if it is less than 8, we can start at 0.1 to 0.2 unit per kg. But can anyone tell me, starting insulin in diabetic population who is already on uncontrolled on OHA is sufficient? Is it sufficient to start only insulin? Optimization is required or not? Yes, so this is where we are going to discuss today, that optimization of insulin therapy is very, very important, and we can go through with the help of our slide. So why we should intensify insulin therapy, when to intensify, what is over basalization, that we have to understand today, and what are the various intensification options, what do the guideline has to say, and what are the barrier of insulin intensification. So first of all, we have already discussed when to start insulin. And this is a very important slide to understand that diabetic pathophysiology starts 10 years before we diagnose the patient. There is initially insulin resistance followed by beta cell dysfunction, and when the diabetes is diagnosed, the beta cell function is 50% less, and there is a peak of insulin resistance. So there is a fasting glucose at normal level because there is high insulin level, but postprandial is uncontrolled, and 50% of the beta cell are already exhausted. So with the going on after 5 or 10 years, again there is a rapid decline of beta cell function, and at that time we require insulin. So we have to explain our type 2 diabetic patient from very beginning that diabetes is a chronic progressive disease, and at any point when your beta cells are not working well or any other complication will happen, according to physician discretion we will start insulin therapy. But when we start basal insulin only, this is a very important slide that shows that only adding basal insulin control sugar for early 3 to 6 years. But after that, there is not good control of glycemic status. So we have to understand starting basal therapy is not sufficient. We have to intensify the basal therapy, and why we should intensify and when we should intensify. So when we should intensify basal therapy? Can anyone tell me? The basal therapy has to do with fasting blood sugar. And if the fasting is not under control and HbA1c is not under control, we have to increase the basal insulin. And second thing is, when the dose of basal insulin is 0.5 unit per kg per day, that means there is a ceiling effect of basal insulin. Now adding more basal insulin will not help to control blood sugar level, and this is the time we have to intensify and add either 1 or 2 or 3 bolus insulin. So this is a very important chart, and that shows that most of the time adding insulin is a reactive phenomena. It should be actually proactive phenomena, that we have to understand the progressive nature of the disease, and we have to start insulin very early and intensify the basal insulin, and once there is a ceiling effect, we have to start bolus insulin as well. So when and why should treatment be reviewed? Why we should review diabetes treatment? Because it is a chronic progressive disease. We have to assess the clinical target whether met or not every 3 months to 6 months. We have to screen for complication every yearly. Discuss the patient's concern. Sometimes you are giving the SGLT2 inhibitor and patient is recurrent having a urinary tract infection. So we have to consider patient's concern, address any problem, reassess patient's needs, and update learning plan, because there are so many new medicines that are available nowadays. And when to increase the or intensify? Every 3 to 6 months we see HbA1c and it is not under control, we have to intensify therapy, and also if there is any complication we have to intensify our therapy. As we already discussed, we should start with low dose and accelerate gradually. And we have to, in morning, Dr. Bansi sir show a wonderful slide from DCCT of Dr. Oscar that says intensify therapy is not adding more insulin. We have to educate the patient, we have to empower the patient, we have to guide patient, we have to advise them, we have to give continued care, and there should be a supportive professional relationship between doctor and patient. In 1990s, when we are seeing the cause of death, out of top 10, 8 will be infectious disease. 8 were infectious disease, but in 2020, out of 10, 8 are non-communicable disease. So now we are no more curing the disease, but now we are carrying the disease. So we have to build a supportive and professional relationship with our patient. And what are the other source of support? We can educate the patient and make a support group. We have an official secondary care support group, structured patient education program that can be happen in your clinic or your area every 3 to 6 months, and we have to educate the whole family, because not a person is suffering from diabetes, the whole family is suffering from diabetes. So this is the insulin optimization, and intensification should follow disease progression, as we already discussed that it is a progressive disease. Initially we start with lifestyle modification and OAD. Then we require a basal insulin with OAD. Gradually we have to optimize, and when the optimization is not sufficient, then we have to give basal plus or basal bolus therapy for the management of type 2 diabetes. So now what is over basalization? Can anyone explain me? I have given already some hint about it, over basalization. So when patient is on basal insulin plus OHA and the dose of basal insulin is 0.5 unit per kg per day, and still the fasting glucose is not controlled, or mealtime bedtime sugar and fasting sugar has gap of more than 50, that is a giving indication that there is a over basalization, and now it is a time to add bolus insulin to the patient. So we have to understand this concept, that there can be a dose of more than 5 unit per kg. AM, PM and pre and post meal are very much different. Hypoglycemia is there and increased glucose variability. They all are sign of over basalization, and at that time we have to add prandial insulin and move the patient from basal insulin to basal plus or basal bolus therapy. Now what are the various intensification options? We can start with basal bolus therapy, 1 basal insulin and 3 or 4 shots of bolus insulin, or we can start with co-formulation where we can give only 2 shots with each major meal, and we can control patient's blood sugar. So what do the guidelines say? Let's understand some guidelines. The ACE has already mentioned that when a person's blood sugars are not under control, we can start basal insulin at the dose of 0.1 to 0.0 unit per kg when HbA1c is less than 8. But when HbA1c is more than 8, the dose should be 0.2 to 0.3 unit per kg, and every 2 to 5 days we should assess the glycemic status of the patient. If the fasting sugar target you have kept 100 to 130, and if it is more than 130, you have to increase the dose by 1 or 2 unit, and if it is less than 100, you have to reduce the dose, and in 10 to 15 days, you will reach at a dose where the fasting glucose are in targeted range for that patient, whether you have kept it 90 to 120 or 100 to 130. But as we already discussed that if the adding only basal insulin will not control the sugar, it is a time to add prandial insulin. Now the question is how we can add prandial insulin. Can anyone tell me? And first, what are the names of prandial insulin? Yeah, for each meal. But what are the available options? Glargine is the basal insulin that we already discussed. Degludec is there. Now, what are the options for prandial insulin? Fias is there. Atrapid is there. Then Lispro is there. So we can start with either 5 unit before the biggest meal of the day, or we can start 10% of the basal insulin, and again every 3 to 5 days we have to measure the postprandial blood sugar and accelerate or decelerate according to the glycemic status of the patient. So this already we have discussed. And ADA in 2025 standard of care also support the basal bolus therapy is the best way to manage type 2 diabetes. So now why we are not starting insulin? Why we are delaying insulinization? Why we are not intensifying insulin? So the $1,000,000 question is, what are the barrier of insulin intensification? Now there is a role of you people that you can guide us why we are not intensifying the insulin therapy. What are the major hurdles for intensifying insulin therapy? Yes, most important is fear of hypoglycemia. Second is why there is a resistance from patient. Fear of needles. Okay, then they don't want to take injection. If the insulin is available as a tablet form, they are taking along with the 10 tablets you have prescribed, it will be 11 tablet. But that is it, injectable therapy, they are feared. So most important thing from physician's mind is hypoglycemia and weight gain. While in the terms of patient, there is a most important is a complexity of therapy. See, I will tell that when you start insulin, start with a basal insulin, explain the patient it is a only one shot that you have to take any point of time during the day, and that will not, it is not related to meal you are consuming. And then patient will accept that insulin. રાધર પહેલી વારમાં તમે એને બેઝલ બોલસ આખું સમજાવી દેશો કે આટલી વાર તારે સુગર ચેક કરવાનું, આટલી વાર ઇન્સ્યુલિન લેવાનું, એ કોમ્પ્લેક્સિટીથી જ એટલો બધો ગભરાઈ જશે કે પેશન્ટ રેડી નહીં થાય. સેકન્ડ થિંગ, વી યુઝ ઇન્સ્યુલિન એઝ અ થ્રેટ. જ્યારે પણ પેશન્ટ ડાયાબિટીસમાં અનકન્ટ્રોલ લઈને આવે, ધેન વી ટેલ કે જો આવતી વખતે આવું કર્યું તો આવતી વખતે ઇન્સ્યુલિન સ્ટાર્ટ કરી દીધું. હમણાં બંદૂક મૂકી એ રીતે આપણે વાત કરીએ. સો વી શુડ નોટ ઇન્સ્યુલિન એઝ અ થ્રેટ. And third thing, કે પહેલેથી જ એને સેન્સિટાઇઝ કરો કે ઇન્સ્યુલિન ઇઝ one of the important central stone for the management of diabetes, and at any point જ્યારે આપણું સુગર કંટ્રોલ સારું નહીં હોય, we have to intensify your therapy by using insulin. So barrier to insulin therapy, 3 most common cause are increased regimen complexity, perception of failure to control the disease. પેશન્ટ એવું લાગે છે કે ઇન્સ્યુલિન સ્ટાર્ટ કર્યું એટલે હવે છેલ્લા સ્ટેજનો ડાયાબિટીસ આવી ગયો, હવે મારો ડાયાબિટીસ કાબુમાં આવશે જ નહીં. સો ધેટ પરસેપ્શન વી હેવ ટુ ચેન્જ, એન્ડ હાઇપોગ્લાઇસેમિયા or fear of hypoglycemia is one of the important barrier for intensify. So we have to overcome this hurdle, or we have to educate them that this is a hurdle race, you have to run this race, we can only remove the hurdles from your path. And this is the data that shows over 75% of the physicians say that they would treat more aggressively if there is no hypoglycemia concern. આ બધાને સુગર કંટ્રોલ તો સારું કરવું જ છે, પણ ઇન્સ્યુલિનના કારણે હાઇપોગ્લાઇસેમિયા ઇઝ મેજર કન્સર્ન. એન્ડ ધીસ ઇઝ મોર ડેટા ધેટ શોઝ મોસ્ટ રિપોર્ટેડ find that insulin related treatment on patient taking insulin at prescribed time and number injection taken are also hurdle. કે પેશન્ટ તમે કહી દીધું કે ભાઈ તમારે આટલા વાગે આ ઇન્સ્યુલિન લેવાનું જ છે. With a newer insulin, we have the longest acting insulin. In a near future, we will have Icodec that will work for 1 week, and we have a rapid acting, a faster acting insulin that even can be taken after the meal. So patient ને સમજાવો કે જમ્યા પછી પણ તમે પ્રેન્ડલ ઇન્સ્યુલિન લઈ શકો છો, બોલસ ઇન્સ્યુલિન, બેઝલ ઇન્સ્યુલિન તમે દિવસમાં ગમે ત્યારે લઈ શકો છો. With Degludec, you have flexibility of more than 8 hours, and with Icodec, they will have flexibility of 1 week. So that will solve problems of the patient's mind. So overcoming the barrier, the perception of failure to control disease, we have to educate the patient, empower the patient, and make patient group that they can educate each other. And hypoglycemia, when we start slow and go slow, there is no chance of hypoglycemia with modern insulin. So to summarize this, I will say that insulinization is need of an hour. We are not going to be diabetic capital, but we have to be diabetic care capital. Our HbA1c is 8.5 to 9 currently, but we have to bring it down to at least 7 to 7.5, because reducing 1% HbA1c will reduce many macrovascular and macrovascular complication in patient. Start insulin at the right time. Start with the basal insulin, either 0.2 unit or 0.3 unit per kg. only starting basal insulin is not sufficient. You have to intensify your insulin therapy according to fasting sugar. But once you reach a ceiling effect of basal insulin, that means there is a gap between mealtime, bedtime sugar and fasting sugar. Also, when the insulin dosage is more than 0.5 unit per kg, or there is severe glycemic variability despite of adding basal insulin, it is time to add prandial insulin. Ideally, you should start prandial insulin by 5 unit or 10% of the basal insulin dose. You have to increase according to the postprandial blood sugar level, and then from basal plus to basal bolus is the ideal way of management of type 2 diabetes. So let's all us unite together to defeat this demon of diabetes and start insulin at a right time, intensify at a right time, and keep blood sugar under control. With that, I would say thank you for silent listening.